So I think many of you guys are probably familiar with immunotherapy in cancer. This is what won the Nobel Prize several years ago. And there are many different types of immunotherapy. So we heard a little bit of talking about CAR T-cell therapy through many of the talks today. We've heard touches on PD-1 and CTLA-4. So this is a broad class of anti-cancer drugs and cell-based therapies. It can include everything from adoptive T-cell transfer, CAR T-cells, oncolytic viruses. All these things are classified as immunotherapy, but I'm going to mostly focus on immune checkpoint inhibitors because these have the highest potential for wide therapeutic adoption. These are massively produced monoclonal antibodies. The same therapy can be used, well, we don't want to say the same therapy in every patient, but we can at least employ that. So it doesn't require patient-specific cells to be harvested, to be modified, and then delivered back to those patients. So it's a very widely adoptable strategy. And namely, those are monoclonal antibodies that target PD-1 and PD-L1 or the CTLA-4 axes. And so these actually function, to be massively oversimplistic about how these drugs work, they function at different sort of arms where if you have a tumor, a solid tumor in this case, those tumor cells are overturning at all times, they're undergoing necrosis, they're dying maybe in response to therapies, and then the guts of those tumors, the protein, the antigens, everything that's within those tumor cells drains through into the tumor-draining lymph node. In this tumor-draining lymph node, there are large amounts of antigen-presenting cells that pick up those molecules. They then present them, and then they activate T-cell responses so that these T-cells can now have a license to leave the lymph node, travel through the circulation all the way back. So they go on this incredible journey to find that site of inflammation where all of this stuff is going on. And so these two therapies, ipilimumab or anti-CTLA-4, works, we think, primarily in the tumor-draining lymph node, where, to really summarize a lot of research here, it's primarily focused on inhibiting CD4 regulatory T-cell responses and also helping to expand the diversity, especially in the CD4 compartment as opposed to the CD8 component. Now, on the other hand, PD-1 and PD-L1, which are perhaps a little bit less toxic, a little bit more widely active of therapeutics, this axis we think is primarily occurring within the tumor itself. There is some research that suggests it can occur in the tumor-draining lymph node, but it's primarily in the tumor itself. It inhibits this interaction between the receptor on T cells and the ligand, which can either occur on many antigen-presenting cells or in some cases tumor cells. The problem with these therapies is massively, as they've sort of overtaken the market, is they have huge amounts of healthcare costs. They have widely variable response rates, and this is really key, unpredictable toxicities. All drugs have toxicities. Chemotherapy, we know exactly when we deliver these drugs what the likely toxicities are. They can be diverse, they can affect a lot of organ systems, but they're fairly reproducible. The toxicities associated with these therapies are spontaneous, they're sporadic, they can be rare, they can affect all of the organ sites. We had a patient a couple months ago that had presented at Vanderbilt after one dose of Ipi/Nivo with renal cell cancer that had Stevens-Johnson syndrome. 80% of his body covered in what appeared to be severe burns. These patients can become type 1 diabetics overnight with a single dose. Now, it's not common. I'm not meaning to scare you with this, but this results in an incredible opportunity to personalize medicine. So just really quickly, these are drugs that are gaining approval on almost a monthly basis for different indications. And this is just a plot showing that over the last 3 or 4 years. They're active in a number of both solid and hematologic malignancies, but they're incredibly expensive. We heard that in the opening talks this morning by Kevin and others, that these agents can be up to $1 to $2 million for these combinations per patient when you factor in all of the costs of healthcare. So non-complex biomarkers that can be employed in almost every patient that are widely adoptable can really maximize benefit and improve cost effectiveness. So I'm just going to start off with something that we actually started studying when I first established my laboratory at Vanderbilt in around 2015, and I was seeing at ASCO these amazing clinical trial results with ipilimumab, and then the combination of ipilimumab and Nivo, and even Nivo by itself. And this is just one slide that sort of summarizes how well these work in a previously a death sentence of a disease, which was metastatic melanoma. And you can see these long tails of patients that we don't want to say cure here, of course, right? But these long tails of patients that have a very long life after, and even even go off therapy and continue to be okay when they had metastatic disease. And so you can see that there is clearly a population responding here with IPI alone. With Nivo alone, we about double that. And with the combination, it's a marginal benefit, but it's a very significant benefit. But the problem is that this combination is incredibly toxic. And so we need to find ways to mitigate that risk and maximize the benefit. And I think this is sort of a mantra of what we're all trying to do here at this conference. And so the current biomarkers, we know that mutation load or total mutation burden by NGS. We can look at inflammation gene signatures. So we heard some talk, at least in the peripheral blood, about the Merck signature, the nanostring interferon signature that's been looked at in solid tumors as a marker of response to these agents. And then PD-L1. So this is an IHC assay. It's had mixed efficacy depending on the tumor type in which you look at it, also depending on the clone and how you titrate the clone for IHC. So it's been pretty problematic. So just really quickly, I'm going to introduce you to this idea of MHC1 and MHC2. So MHC1 is the molecule that is very widely expressed on almost all cell types. It presents everything that's being processed from a protein level in the cell and made to CD8 cells. And when those peptides are not self, they can tip off and activate a CD8 response. On the other hand, MHC2 can actually present the same sort of peptides, but much longer, to CD4 cells. And typically what we think of is the CD8 cells are the ones that are cytotoxic and kill tumor cells, for instance, or virally infected cells, but those can't live and exist for very long without CD4 help. And this is the way that the system works from a very simplistic perspective. Now, MHC1, as I mentioned, is expressed on almost all cells in the body. MHC2, on the other hand, is sort of canonically thought to be only expressed on professional antigen-presenting cells. These are dendritic cells. These are your B cells. Many macrophages can express class 2. However, we and others have noticed that in melanoma and many other tumor types, the tumor cells themselves can express class 2. This suggests that they might be able to actually present class 2 restricted antigens to CD4 cells and that might be meaningful. And in fact, that's what we see. And we started off very early in looking at melanoma using SOX10 here as a specific marker for the melanoma cells. And what you can see is just as we would expect, we see lots of HLA-DR, MHC2 staining here and some histiocytes near the tumor margin, or here a large number of presumably B cells, lymphocyte sort of morphology. But we also found these tumors, these melanomas, where the tumor itself was expressing a large amount of MHC2. This is a very easy antigen to stain for by immunohistochemistry, and it produced this very robust response where when we started, this was very early on in the days where it was hard to get these sort of samples. Now people have hundreds and hundreds of immunotherapy-treated melanoma data sets. But what we found was when we said, okay, these are associated with more inflammatory microenvironments, and we see more CD4 cells, so do they actually respond to immunotherapy better? And in fact, we did both a discovery and a validation set. In this day and age, this would be considered quite small, but in both of these, we found that those MHC2 positive tumors did much better, both in terms of progression-free survival and overall survival in response to immunotherapy. We worked with a company called Navigate, which is owned by Novartis right now, and we incorporated what sort of the expectation was here, PD-L1 immunofluorescence, and we did an interaction score with them. So the closer that the PD-1 was to the PD-L1 in the tumor microenvironment, this helped catch a few more of those patients that were responding to therapy that we missed by our MHC2 assay. And actually looking at, in this case, about 150 metastatic melanomas through several different institutions and doing a central analytical analysis at Navigate, we were able to do a very, very nice job of at least identifying those patients that are candidates for PD-1 therapy that are going to respond at an 80 to 90% response rate. Interestingly, MHC2 has now been a more broadly identified biomarker. It's been found to be a significant predictor of outcome on PD-1 therapy in the Reed-Sternberg cells of Hodgkin's lymphoma. And so this actually prompted us to look a little bit deeper. So MHC2 is actually the ligand for another checkpoint receptor called Lag3. And Lag3 is in late phase clinical trials now, some exciting data that should be reported out of some of these clinical trials being read out in the near future. So interestingly, we had this idea that so if you have a tumor that's responding because it's presenting lots of antigen to CD4 cells through class 2, what would be the normal tumor mechanism or tumor microenvironmental mechanism of resistance to that? It might be to upregulate a secondary checkpoint like Lag3. And so in fact, we gathered a number of melanoma samples that had initially responded to single-agent PD-1 therapy and then relapsed. And what we saw by staining for LAG3, I appreciate this is a little bit hard to see on this particular projector, we saw lots more LAG3 positive lymphocytes in those relapsed specimens. And so what this suggested was this high PD-1 reliance in tumors that were class 2 positive that had both many CD8 and CD4 cells. But when those tumors became resistant, they sort of leveraged that high expression of class 2, and that would guide sort of a reliance on LAG3. And so in order to test this, we got funding from Bristol Myers Squibb to conduct this sort of personalized melanoma immunotherapy trial where we've developed a CAP-CLIA assay for MHC2 in situ with immunohistochemistry. And those patients that have high MHC2 positive tumors are now stratified or allocated rather to nivolumab plus relatlimab, which is the LAG3 antibody. So we're trying to address resistance up front here in this population. And actually in the MHC2 negative tumors, these are the patients that have a lower response rate to single agent PD-1. They have lower CD4 cells, and actually this is what gets mobilized with anti-CTLA-4. So we're trying to, again, try to mitigate the risk and maximize the benefit by using a personalized immunotherapy strategy. And so many of you guys may be familiar, I'm actually a breast cancer researcher at heart. I got into melanoma so that I had an opportunity to study biomarkers in where the disease was being treated with immunotherapy on a frequent basis. And so now we're really excited to start to translate these findings to triple-negative breast cancer, where we just got our first approval for immunotherapy, anti-PD-L1 or atezolizumab in combination with nab-paclitaxel. And so I was incredibly excited to sort of randomly be on this phone call for the I-SPY2 trialists. And many of you guys may be familiar with the I-SPY2 trial that's being done across the country and actually, I believe, at international sites as well. So there was these data that were just released at ESMO this year in this city just several months ago, the Keynote 522 trial. So we have metastatic triple-negative breast cancer where we're treating with atezolizumab now. This was neoadjuvant setting, so patients diagnosed, and before they even go to surgery, they would normally get chemotherapy. But now chemotherapy plus pembrolizumab or anti-PD-1 therapy showed an incredible response rate in primary triple-negative breast cancer. And that read out just recently, but the trial that led to that was called the I-SPY, was one of the arms of the I-SPY2 trial. And this included a number of different biomarker analyses, and we're going to hear from one of those investigators in Emmanuel or Chip Petricoin's lab right up next. I found out that they were just about to release at ASCO this year their analysis of this trial. So all of the patients that benefited in terms of a pathological complete response to the addition of pembrolizumab, they looked at 40 to 50 different biomarkers in the tumor cell compartment of these tumors. And the massive, the overwhelming majority of those had very high MHC2 expression in the tumor compartment, whereas the same effect was not seen in the neoadjuvant chemotherapy alone patients. So this was over almost 80 to 90% of the patients that had high MHC2 expression had a complete pathological response. And this is almost a cure in triple-negative breast cancer. So this means that very, very few of those patients are going to recur after surgery. So we were very enthused to see these results and maybe have a chance to work with Chip's lab in the future on this. So in conclusion, the cost effectiveness of immunotherapy at this point in this growing field hinges on appropriate patient selection. We've shown you one of the trials that we've now incorporated to try to help guide the field in this. So to take these combinations and use biomarkers to stratify patients to the right immunotherapy combination in each case. And so with that, we're hoping to, again, getting back to managing risk and benefit, and we have a big portion of our lab as well as we conduct these studies. They're trying to understand some of the mechanisms and the biomarkers behind these very severe immune-related adverse events that I just told you about. So with that, I'd like to acknowledge our funding sources and the people that actually do the work. And these are the few of the people that have now left my lab. So we've been around for 5 or 6 years. And you can tell that they've left the lab because they all seem a lot happier than everyone here. So thank you.